എത്ര കേസ് വർഗീസ് ഡിസ്കസ് ചെയ്യേണ്ടത്? 4 ആണോ?
ടൈം മാതിരി നമുക്ക് 6-7 കേസ് ഉണ്ട്. പക്ഷെ 4 കേസ് ഓരോന്നിനും 15 മിനിറ്റ് എടുത്താൽ 20 മിനിറ്റ് എടുത്താലും വീക്കാൻ.
അതെ, നമ്മൾ അവര് പരീക്ഷ ഉള്ളതുകൊണ്ട് നമുക്ക് കുറച്ചും കൂടി ബ്രീഫായിട്ട് പോവാം അല്ലേ?
അതെ. എട്ട് മണിയാവാൻ പോകുന്നു. ഇന്നത്തെ ഡിസ്കഷൻസ് ഡോക്ടർ റോഹൻ ഫ്രം സിംസ് ചെന്നൈ. Dr. Rohan, are you there?
Yes, sir. I am there, sir.
Okay, good evening. Welcome to today's session.
Good evening.
And Dr. Jagdish Reddy from KIMS, Trivandrum.
Yes, sir. Good evening, sir. I'm here.
Good evening. So, best wishes to all of you. Because it is OSCE only, we'll be asking only OSCE related issues and something related to that. And okay, even if you are not able to answer it, don't bother about it, just refresh it. Because of OSCE, we are asking some theory questions as well. Okay, so those things, the OSCE style has changed. They may simply show some picture or a video and ask anything about it. So some theoretical knowledge also is important. It is.
Shall we start?
Yeah, it's 8 o'clock now. Shall we start, sir?
Yes.
Good evening, everyone. Good evening, Shanai sir, Dr. Prakash Sakriyas, other faculty members, and my dear students. Welcome to ISG Kerala Chapter PG Clinics. We have done this PG Clinics ever since July, and I hope these PG Clinics benefit our residents not only in Kerala, Tamil Nadu, and rest of India. Our PG Clinic Facebook group has more than 250 members who are actively listening to the program, and because the records are also available, they are able to listen it later as well. For today's discussion, we have 2 senior faculty members. They have been introduced earlier. Professor K.T. Shanai, former head of Department of Government Medical College, Tirunelveli. At the moment, sir is working as the head of Department of Gastroenterology at Sri Gokulam Medical College and Research Center, Tirunelveli. Along with Shanai sir, we have a very senior gastroenterologist of Kerala, Dr. Prakash Sakriyas, who is a senior consultant working with the Institute of Gastroenterology at Kochi. Dr. Prakash is the president of ISG Kerala chapter and has been instrumental in getting this clinics done. It was after his request that we started this program. And Dr. Prakash is also a very good endoscopist and bagged the SGI Best Endoscopy Award recently. And I will also welcome all the other faculty members and other students. And for the discussion today, we have Dr. Rohan from SIMS Chennai and Dr. Jagdish Reddy from KIMS Trivandrum. So the first case will be discussed by Dr. Rohan, and we will start the clinics now. You may have over to the faculty. Do you have to say anything, sir?
Well, I think welcome both the students, and I must tell you that this session will be a very friendly session. There will not be any nagging. We want to understand the topic together. We have to learn together, and that is the concept of these 3 or 4 cases which we are going to discuss. At any time you feel that the question is very difficult, I hope you will communicate that this question may be repeated or may be answered by the faculty. I think take the clinics as a good teaching exercise. Nevertheless, it will be definitely of some information to you, but we will never use any harassment to any of the students who take part in this particular course. Thank you, Varghese, and we start now.
Yes, sir. So, good evening, sir. Yes.
Sir, Shane sir, can you be a little bit closer to the computer so that we can be a little more louder? Okay.
Yes.
Dr. Rohan, please start.
Yes, sir. So, case 1. This is a 62-year-old lady, type 2 diabetes mellitus, high blood pressure on treatment, long-standing reflux symptoms for the past 15 years, was on PPIs intermittently, on-demand therapy, stops when symptoms are relieved, history of asthma for the last 5 years, non-productive cough on and off, more at night, mild hoarseness of voice for the last 2 years, recent exacerbation without odynophagia, weight gain 5 kg for the last 1 year. Weight is 68 kg. BMI is 23.4 kg per meter square. Blood pressure is 160 by 96 millimeters of mercury. There's mild truncal obesity. Chest is sparse fine bronchi are present bilaterally. On the endoscopy, there is lax gastroesophageal junction at 35 centimeter. Small hiatus hernia is present. Grade A esophagitis is present, and Barrett's esophagus lower 3 centimeter. So histopathological examination shows Barrett's esophagus with moderate dysplasia. So diagnosis of hiatus hernia, grading of Barrett's esophagus. So hiatus hernia diagnosis can be made based on 2 things. One is there is proximal migration of the gastric folds above the gastroesophageal junction. So measuring the distance between the gastroesophageal junction and the squamocolumnar junction, that gives a approximate idea of the presence of hiatus hernia. Second is the Hill's classification, which gives an approximation of the laxity of the lower esophageal sphincter. If on the endoscopy, one can see gastric folds above the diaphragmatic constriction into the lower end of the esophagus, that suggests a hiatus hernia. So this is typically a sliding hiatus hernia. There can be other types of hiatus hernia, like paraesophageal hernias, where one can notice that on the retroflexion or on the J maneuver in the stomach, which can be seen as a paraesophageal hernia. Coming to Hill's classification has 4 grades. One is lax LES with respiratory variations of the lower esophageal sphincter constriction and relaxation. Second is when there is persistent opening or space between the endoscope on the retroflexion and the lower esophageal sphincter. Grade 3 is when the distal end of the esophagus is visible from the lower end of the sphincter, and grade 4 is when the Z line is also visible from the on retroflexion. That is Hill's classification for the lax LES and hiatus hernia. Coming to
when you do endoscopy, what are the few landmarks which you look at the lower esophagus or at G?
Yes, sir. So first landmark which we look on the endoscopy is the squamocolumnar junction. That is the Z line, which can be regular or irregular. And then the second landmark which we look at is the diaphragmatic constriction or the esophagogastric junction, where there is which generally coincides with the esophagogastric junction, which is the beginning of the gastric folds of mucosa. If this junction is proximally migrated, then we say it is hiatus hernia.
So there are 3 landmarks. So actually, so that is the one is the diaphragmatic hiatus. The second is the top of the gastric folds or the G junction, and the squamous columnar junction. So
Yes, sir.
when would you look at it? So while going in or while coming out, or what is the time when you assess?
Ideally, yes, sir. There should be sufficient insufflation, and ideally, while coming out or on withdrawal, we'll look at the
So
OG junction
it's
and
usually seen and assessed while coming out. So that is the time which you assess these three landmarks.
Why
Yes,
do
sir.
you want to take Dr. Zakaria?
Yeah.
We must find out from them, why do they want to assess it when they are coming out of the stomach into the esophagus?
Rohan.
Yeah, I think the presenter can answer if he knows this answer.
Rohan, the question was that why are you not doing it when you are going in, and why do you specifically do this when you take the scope out of the stomach into the esophagus?
Sir, I'm not very sure about the reasons.
I think the answer is that the stomach should be fully deflated. You should suck out all the air. This is because many a time the hiatus hernia will be associated with the Barrett's. So in the diagnosis of a Barrett's, if you look at the first diagnostic criteria, which is your second question, grading of the
Yes, sir.
Barrett's. After you answer
Yes,
this, I will tell you how do you answer this question.
Yes, sir. So Barrett's esophagus can be graded into a short segment or a long segment Barrett's. That is depending upon the length above the squamocolumnar junction. If it is 3 centimeter above the so that is either shorter than 3 centimeter is a short segment, more than 3 centimeter is long segment Barrett's. And there is a Prague classification which we use for grading of for defining the extent of the Barrett's esophagus, which has two components. One is the circumferential margin and of the squamocolumnar junction, and the other is the maximal extent or the M. Circumferential extent of the columnar epithelium is called as C. That is calculated from the OG junction, that is the beginning of the gastric folds. So C is the distance between the circumferential margin of the columnar epithelium and the beginning of the gastric folds, and M is the distance between the maximum extent of the tongue-shaped projection or the columnar epithelium and the beginning of the gastroesophageal fold, gastric folds. So this way.
So this way you classify as the C and M classification, and then you grade it. To make the correct assessment of the C and the M, the stomach should be completely deflated. And then when you take the scope from the stomach into the esophagus, you start measuring it, as you already suggested. I think those of you who are doing endoscopy and want to assess the Barrett's, there is a beautiful video which is available, which is hosted by the group which gave the Prague classification. There's an international group led by Dr. Pratik Sharma and others. So this video is available in the net. I happened to get this video directly from Pratik Sharma. This is an information for you because we were carrying out a population-based study of gastroesophageal reflux disease and Barrett's, supported by Dr. Pratik Sharma and Dr. Nicholas Talley, way back in 2011, 2012. This study is almost complete now. So in this study, to understand the endoscopic findings, Dr. Pratik transferred these videos to me to learn how to grade the C and M and what are the criteria to be adopted before you grade them as C or M or histological evidence of Barrett's. Now, when you say the histological evidence of Barrett's, what is the criteria which you use?
Yes, sir. So there should be either gastric or intestinal metaplasia in the columnar epithelium, which is protruding into the esophagus.
How do you know it is columnar?
Presence of goblet cells and
Okay. Ideally, when you do a biopsy in a Barrett's, there is a system. This system is that you should pass the endoscope into the duodenum and take a biopsy from the first part of the duodenum. So you compare the epithelium with the first part of the duodenum. That is how you really classify as having intestinal metaplasia. You have to look at the epithelium, and the comparator is the duodenal mucosa. So you have to do first a duodenal mucosal biopsy. Then you have to use a classification for getting the biopsy from the stomach, which is 5 different sites of biopsy. This is not, I am not going to discuss with you. Then when you take a biopsy from the Barrett's, there is a system of taking biopsy. Do you know how to take the biopsy?
Yes, sir. These should be 4-quadrant biopsies and taken every 1 centimeter if it is high grade dysplasia, and every yes, sir, 1 centimeter if it is high grade dysplasia, and during the surveillance, if it is a known dysplasia, you can take it every 1 centimeter.
No, not surveillance. Not surveillance. We are making a diagnostic approach.
Yes, sir.
When
So
you make
the
first
ACG
diagnosis-
guide. Yes, sir. The ACG 2018 guidelines recommend that 4-quadrant biopsies every 1 centimeter in the Barrett's epithelium. That is, these biopsies have to be taken.
These biopsies have to be taken circumferentially in the
Circumferential
four quadrant, and then you have to put these biopsies into one bottle or separate bottles.
Sir, I'm not sure about this.
You can put them all in one bottle, no
Yes.
problem. And then you should have a duodenal biopsy. And there is a system of collecting biopsy from the stomach, which has to be separate. The anterior corpus, the posterior corpus, lesser curvature, greater curvature. There is a system of taking biopsy. They are very important in first to assess the grading of Barrett's. Secondly, whether it is really Barrett's. And thirdly, you want to know whether there is an association with H. pylori or no H. pylori. That is the reason why you have to take multiple biopsies. Dr. Prakash, you can ask few questions to him.
Rohan, do you know the name of this biopsy protocol?
The stomach biopsy protocol is the Sydney
Not the
protocol.
stomach, sir. This
Yes.
Barrett's biopsy protocol. This is called Seattle biopsy sampling
Seattle.
protocol.
Seattle. Yes.
Right. So, right. We'll carry on.
Sir, I forgot to mention on the endoscopy, with the help of NBI, we can even find out about the Bing classification that can give us a rough idea about the grading of whether the Barrett's esophagus is present or not.
In addition to this routine biopsy, if there are any mucosal abnormality, you have to take separate targeted biopsy from that also.
Yes, if there are some nodules, you have to take definitely a biopsies and keep them separately.
Yes. Yes, sir. So the management issues in this case, this lady seems to have long-standing gastroesophageal reflux disease. She's on proton pump inhibitor therapy on demand, and she has Barrett's esophagus with moderate grade dysplasia. So this qualifies for surveillance as well as first the diagnosis, confirmation of the diagnosis, because it is only endoscopy picture which was shown. So I would first like to do an biopsy and confirm the diagnosis, and then based on the histological grading, decide on further. So I'm sorry, this lady already has moderate grade dysplasia. So she would go into a surveillance protocol. What are the supraesophageal symptoms of GERD and its mechanism? The extra esophageal, so supra should be supra.
Okay, you can call it extra or supra.
Okay, sir. Yes, sir. So
whatever it is, what are the other manifestations?
yes, sir. So The definitive extraesophageal manifestations are aspiration, cough, asthma, hoarseness of voice, change in voice, prolonged throat warming, dental caries, altered sleep, obstructive sleep apnea, and pharyngitis, laryngitis. These are some of the extraesophageal manifestations of GERD.
One more thing is that there is otitis media.
Yes, sir. Otitis media.
So you mentioned about asthma. What is the characteristics of asthma?
There will be wheezing in these patients. Two reasons, sir.
Wheezing is
Both
a feature. It
Yes,
will
sir.
be mostly nocturnal asthma.
Nocturnal because of the bronchospasm, because of the vagal reflux secondary to the gastroesophageal reflux. The second thing, in a patient, in an asthmatic patient also, because of the use of bronchodilators, there may be relaxation of the lower esophageal junction, which may contribute to reflux. So it's a bidirectional phenomenon where GERD can be associated with asthma and asthma itself can be associated with GERD.
Next 3 questions you can take together.
Yes, sir. How will you manage this case? This patient has a moderate grade dysplasia, so she would fall into the surveillance protocol based on the biopsy, and she would go as per the ACG guidelines. She should be undergoing surveillance every 2 to 3 years, surveillance endoscopy. Since there was no irregularity or nodularity, there is no point of doing an EMR or a further endoscopic eradication therapy in this case. How will you manage her hiatus hernia? So hiatus hernia.
Before that, Rohan,
Yes, sir.
whenever there is a dysplasia which has been mentioned by a pathologist, as per the recommendation, it is always it has to be confirmed by a second pathologist. So that is the first thing when there is a dysplasia, and the dysplasia usually either whether there is it's no dysplasia or a low grade or a high grade. This is how for Barrett's it is mentioned. So the first thing is to confirm the presence of dysplasia by a second pathologist who is well versed with the Barrett's esophagus and neoplasia. So that is then
Dr. Prakash brought out a very important point here. There is a high degree of variability between two persons in the interpretation of an esophageal biopsy for Barrett's and dysplasia. And the same group which has given the prior classification, they have told that if there is more than 2 pathologists who can review the slides, the diagnostic yield is much more, and the chance of a negative diagnosis or a false positive diagnosis can also be brought down. I think this is very, very important. The pathologist should be really an expert, because otherwise you will put them unnecessarily into a surveillance program, and the economic cost, the economy for a surveillance will be very huge. So you should be very, very careful when you say the level, the degree of dysplasia. And I agree with the Prakash that even in the same center, there should be an expert pathologist who should review the slides.
Right. So in this patient, we'll take this as a low-grade dysplasia, and so in that, what would be your recommendation?
So for low-grade dysplasia, the recommendation would be to do a surveillance endoscope. The risk for malignant transformation is just 0.1 to 0.3% per year. And for low-grade dysplasia, it may be as about 0.7% per year. So thus the protocol would be to do a surveillance endoscopy every 2 to 3 years as per the AGA recommendations. In case the patient has further risk factors such as obesity, family history of malignancy, and smoking, then I would like to do a aggressive surveillance.
Aggressive means what? Aggressive means what? What do you mean by
Annual
aggressive
surveillance.
surveillance?
Annual surveillance.
No, I don't think annual surveillance is of great use. People have been thinking of annual surveillance. If the dysplasia is mild, I think the yield of an annual surveillance will be very, very low. So in fact, I think it will be better to have either once in 2 years or once in 3 years. People are modifying this criteria again and again. Earlier, it used to be almost like an annual, but now it has been extended further. Other than if there is a family history of one of the relatives having a malignancy, then I think you should be probably doing it a little earlier than the usual recommendation.
Yes.
Dr. Prakash, anything you want to add on to this surveillance in mild dysplasia?
So in the mild, the low-grade dysplasia, there are some aggressive thing also where they recommend a yearly surveillance. But as you said, they have got a very low risk of transformation into endoscopic, into esophageal adenocarcinoma.
What is your practice, Dr. Prakash? I think you may be seeing a lot of Barrett. Do you get any yield of from surveillance when you do this for the so-called low-grade dysplasia?
Luckily, the number of patients whom we get for Barrett's with dysplasia is less, and those patients who are referred to us for treatment are usually who have got some high-grade dysplasia or an early malignancy or a carcinoma in situ. So otherwise, in our patients with low-grade dysplasia, we the yield of picking up malignancy in the later is very less, very low.
Okay, I think the question is how will you manage this case and how will you manage the hiatus hernia? Have
Yes,
you completed answering this question?
Yes. So hiatus hernia can, so for management of this case, if it's a low-grade dysplasia, we can go for the 2 to 3 yearly surveillance protocol. For managing the hiatus hernia, there are it can be the definitive management would be a surgical therapy, which can be offered if the patient does not wish to take long-term PPIs. In that case, if the GERD is troublesome, I can offer a surgical procedure such as fundoplication, which can be Nissen's anterior tupate or posterior torque fundoplication. So these are the definitive management for the hiatus hernia. Regarding does Barrett's require extra management? If in case this Barrett's the Barrett's esophagus in this case, if this had nodularity or irregularity, then it would have required extra management. But the presence of Barrett's itself, it is just a pre-malignant condition, so it requires surveillance rather than any extra management if high-risk features are not present. What are the methods to detect dysplastic epithelium in Barrett's to target biopsy? There are various methods. One is the digital chromoendoscopy or the conventional chromoendoscopy. And the digital chromoendoscopy or the narrowband imaging has a classification system called as the Bing classification or Barrett's International NBI Group classification, where we see the mucosal pattern and the vascular pattern. Mucosal pattern, whether it is regular or irregular, and again the vascular pattern, if it is regular or irregular. In the mucosal pattern, patterns such as circular or pit pattern, ridged pattern, or Willis or cribriform or tubular pattern is regular. If these are irregular, it is considered as abnormal. Vascular pattern can again be regular or irregular, and whether it is focal, I mean the irregularity is focal or diffuse, that needs to be graded. And it has about 80 to 85% positive predictive value for detecting Barrett's esophagus and for targeting the biopsies.
Next, modified test methods of treatment for high-grade Barrett's.
Rohan, have you read the ASG guideline on screening and surveillance of Barrett's in 2019?
And the AGA guidelines I've read, sir. ASG have not read.
There is a guideline, as Dr. Prakash mentioned. There is an ASG guideline on screening and surveillance, which is somewhere in 2020, 2019, 2020. I think this was the standard of practice. It's a beautiful paper. I think you should go through this. As you mentioned about the screening by white light or the chromoendoscopy or others, there are some good recommendations which have been given in this guidelines.
Yes.
Dr. Prakash, can you just spell it out for the benefit of the students? Which guideline?
This is the ASG guideline.
ASG, American Society of
Endoscopy guidelines is there. That is a 2019 guideline. It's something. It's one of the latest guidelines actually, which is available. So, ASG Standards of Practice Committee has.
This is prepared by ASG Practice Committee, which is there is a final document which is available. I have actually projected in front of me when I am speaking to you. This is chaired by the ASG Standard Practice Committee Chair, Sachin Wani. And it's a beautiful guideline which has given many aspects which we are discussing today, comparing between the white light endoscopy or a endoscopy with enhancement using the Seattle protocol, which Dr. Prakash alluded to. What is the diagnostic yield and all the aspects. I think very beautiful questions which have been raised. I think if Varghese is able to get them through, or I can send them to Varghese and then he can upload this. The two guidelines, which one is the ASG and second is the Pratik Sharma, and the other guideline is by Pratik Nicola Shaheen, the clinical practice guidelines, which of its 2019 gastroenterology.
Sir, if you have the PDF, you can send it to my email. I will circulate in the group.
I have both the PDF. Straight away, I will mark it to you, and at the end of the discussion, you can send them to them.
Thank you, sir.
The difference between the two guidelines is the Pratik Sharma's guidelines is very interesting. It starts with a beautiful statements. I think this is very useful for the students, that he has given a number of best practice advice, starting with the 1 to 14 best practice advice. And I think that is something which they can learn. What is the preferred treatment with high-grade dysplasia? What is the surveillance options? So I think I will send straight to Varghese, and you can transfer it to them.
Yeah, there is another guideline also from ASG that is on endoscopic eradication therapy for patients with Barrett's esophagus.
Okay.
Associated dysplasia and intramucosal cancer. That is in 2018.
I think Prakash can send it to Varghese, and then he can make a PDF. So 3 of these guidelines will be very useful for them in terms of looking at which are the best practices for Barrett's esophagus.
Yes. Thank you, sir.
Okay, just mention the name, because if you because of the interest of time, just mention the method.
This mentions this particular guideline mentions about the endoscopic eradication therapy, even in low-grade dysplasia. So that is something, if someone asks you about that, you can read about it, and you can mention that in your answers.
Yes, sir. So briefly, the methods of treatment of Barrett's esophagus can be either endoscopic mucosal resection or endoablative therapies such as photodynamic therapy, which was previously used, and currently favored therapy is the radiofrequency ablation, the RFA therapy. And the endoscopic mucosal resection is the more definitive therapy, because on the biopsy specimen we get to know about the depth of invasion, and that may help in deciding whether further endoablative therapy needs to be given or not. Coming to the last question, what is buried syndrome in
So in
relation?
this so when you do the endoscopic eradication therapy, so what do you do? I mean, resect is those endoscopically visible lesions. Okay, so all these visible lesions are resected, and for the rest of the lesion, this radiofrequency ablation is applied. So that is how it is done. So the other than the radiofrequency ablation, argon plasma coagulation is another method which has been used in studies. So, but the treatment of choice, one is those visible lesions are resected by endoscopic mucosal resection, and the rest is ablated by radiofrequency ablation.
Yes.
So this radiofrequency ablation, this is a concentric ablate. It's a special radiofrequency ablation method. Okay.
Yes. The last question, the buried syndrome, that is subsquamous intestinal metaplasia. What happens is when an endoablative therapy is done, if it is done incompletely, what happens is when there is regeneration of the new mucosa over the damaged or the ablated mucosa, the epithelium which is underneath, which may be dysplastic, that can get buried beneath the new generated mucosa, and that is called as the buried syndrome. This was a concept which was previously followed, but at present in the current era, the AGA recommends that this is an outdated thing. Like it is
Probably not much relevant nowadays.
not much relevant. Yes.
Okay.
I think Varghese, can we close this session? And I think he has presented very well and he has reviewed the topic. I think I will definitely give him a high percentage of pass, something like 75 to 85%. I think yes. I think I am now taking it more like an examination. 75 to 85% is the scoring which I think he has achieved. And I hope this session will be useful, except Barrett's is something which you have to really learn how to detect it. We say Barrett's is not very common. This is not true. I think once you do a good endoscopy, you take all the air from the stomach and carefully watch, put the NBE, you are definitely able to see more evidences and more Barrett's in your clinical practice. I think it is there, but dysplasia with high-grade dysplasia, moderate dysplasia, they are not very common. But definitely Barrett's is coming up as a good issue in our population.
Thank you, sir. Thank you very much. The discussion was very interesting. And also thank you, Dr. Rohan, for that wonderful way in which you discussed the case. Congratulations, Rohan, and keep it up. Okay. And we'll move to the second case, Dr. Jagdish.
Yes, sir.
Jagdish Reddy from KIMS, Toronto. Dr. Jagdish, please.
Sir, good evening.
Okay, welcome to today's session. And this is your case.
Yes, sir. 36-year-old male, bleeding pair since 4 weeks. How will you elaborate the history to make clinical diagnosis? Sir, bleeding pair, so I want to know either it's a painless bleeding or painful bleeding. The quantity of blood, either it's a fresh blood or any altered blood associated with clots or associated with blood clots were there or not there.
Please tell the relevance of each of your questions also. Relevance of each of your questions.
Yes, sir.
Like painless bleeding, painful bleeding.
So painless bleeding, basically to rule out either it's a hemorrhoidal bleed or bleed from the bleed from the above, sir. Like sigmoid
painless
or,
can be anything, and painful can be few. So just elaborate on the painful, and then rest of the things can be painless, no?
Yes, sir. Painful will be from the anal fissure or any thrombosed hemorrhoids causing painful bleeding, sir. And next one will be the quantity of either it's a fresh blood or altered blood. Fresh blood means mostly from the anal region or from the lower rectum, just above the anal region. If altered blood means it will be from the above the upper rectum or from the left side of the colon. And
I think that may not be true. I think altered blood and fresh blood, I think blood is blood. If you said a red blood, I think it can be anywhere from the rectum to the cecum. But sometime in the cecum, you may get a little altered blood. But anything which is coming from the right colon, either ascending colon, transverse colon, hepatic flexure, or the descending colon, the blood will be quite red. I think the only thing is the cecum is an exception where you may not get the actually red blood. It may be a more altered blood. Otherwise, I think the bleeding for rectum means it is red blood, rectum or colon, colorectal bleeding. As Dr. Varghese asked you, the painful causes are very few. One is coming from hemorrhoids or from fissure or even a distal proctitis, a radiation proctitis. There will be bleeding and there will be severe pain, radiation proctitis or even a proctitis. So there will be pain in this. Whereas a pain of bleeding occurring from a polyp or a growth or any other bleeding site like a diverticulum, they all will be a painless bleeding. But occasionally they can be painful in a polyp if a polyp presents with intussusception. The polyp has an intussusception and then you get a bleeding. So there will be a pain followed by bleeding. But the pain is because of intussusception and the bleeding is secondary to that. So you should all think about how they come and how they present. It is the constellation of symptoms which are very important to make a diagnosis, not the pain or alone, how they come as a complex. Pain followed by bleeding or bleeding without any pain or the distal or rectal pain and bleeding, that makes you think that it is a local cause or it can be others. Dr. Prakash, what is your opinion?
Yeah,
because this is
I agree with you, sir. The only thing is that if the rate of bleed or the rapidity of the bleed also might contribute to the change in color. Like if it is a slow ooze from the right colon, then the color might change a bit, would change. Otherwise, as you said, when there is a rapid bleed from anywhere in the colon, it would be bright red. But if it is
even a stomach bleed, if there is a massive bleeding, it will come as a red blood. I think we have seen this. Meckel's diverticulum. It will be, suppose there is a torrential bleed, it will be a red blood.
Yes, sir.
Okay, we will proceed.
This will not be taken for your assessment of marks. This is to give you some information because your assessment is done already by question from Dr. Varghese. I think we are giving you some more information which will be of use in the clinical practice.
Okay, sir. And then I want to ask either it's mixed with stools or not mixed with stools. And is there any associated with altered bowel habits like history of constipation or intermittent constipation and followed by diarrhea or any history of spurious diarrhea? Any history, I want to ask any history of intestinal obstruction feature like abdominal distension, Barbagnesians, or any and this abdominal pain associated with this bleeding PR.
Is medication history important?
Yes, sir. Medication history important. And then I want to ask about past history, personal history, medication.
Okay, agreed.
History.
I am asking you again, what is the relevance of the medication history?
Sir, if the patient is taking any non-steroidal anti-inflammatory drugs, there is a chance of ulcers NSAID induced ulcers in the.
Yes, remember that ulcers can be in the small intestine as well as large intestine. In fact, some of the NSAIDs can produce proctitis, which may look like IBD. Okay, so it can occur like that. So can we move to the next slide? Okay.
And on examination, patient is a healthy adult. Abdominal examination, there is no abnormal findings. For rectal examination, no abnormal detected. Anoscopy, no hemorrhoids. Came with a colonoscopy report. Colonoscopy showed multiple polyps, about 18 number, distributed mainly in the left colon, sigmoid and rectum, size 0.5 to 1 centimeter, both sessile and pedunculated. What additional information you will elicit? So,
Apart from biopsy,
sir,
apart from the histopathology will be obvious then. Do you want any other information?
sir, I want to, like in the clinical examination, I want to ask any pigmentation is there.
Okay, good. Why?
In buccal mucosa, if is any macular hyperpigmentation, I want to rule out the Petzover syndrome, sir. And is there any epidermoid cyst is there or not?
Okay, general examination didn't see any of these things.
Yes, sir.
What other
And,
history you want? Don't you want to get a family history?
Yes, sir. I want to.
I think that
history.
will be the first history which I will be taking. Suppose you have got a multiple polyps.
Yes, sir. Family history.
To you want to know what is the whole disease in the family, at least in 2 or 3 generations. Take a good family pedigree, starting from grandfather, grandmother, father, mother, other siblings. I think draw a good family tree. I think that will be the most useful rather than looking at pigmentations. These are all colonic polyps, and you are looking for Peutz-Jeghers. 90% of the polyps in the Peutz-Jeghers will be distributed in the small bowel. They
Yes,
can
sir.
have colonic polyps and polyps elsewhere. But what I will be more interested is to get a good family history.
Okay, sir. And family history of personal.
Dr. Varghese, any family history of any?
Yeah, the family history shown.
Family history of CA colon for fathers, elder brother, diagnosed at age of 52 years. Then father's sister had breast surgery for lump at 58 years. Will diagnosis change according to family history? Enumerate the various differential diagnosis of polypoid lesions in the colon. Yes, sir. If is
Are you there, Dr. Jagdish?
yes, sir. I'm here, sir.
Okay.
So
What
The aim of the question was that whether it
Yes,
is a sporadic polyposis, and if at all there is a CA, whether it is a sporadic cancer versus whether it's a familial polyposis or a familial cancer syndrome affecting the colon. So from the history, if we take extra care, we may be able to find it out from the history. As you rightly said, general examination, one should look for osteomas, fibromas, pigmentation, and other things, which will also give us a clue. Okay. Now, our question is that will the diagnosis change according to family history? You may think that this is a few polyps, it may be sporadic disease. Well, if there is strong family history like CA colon or other carcinomas in the family, what are we concerned about?
sir. Because of significant family history, we need to consider like polyposis syndrome, sir. Hereditary polyposis syndrome, more likely.
Okay, but I doesn't have a polyposis,
Do you think
polyps.
he has polyposis?
8 polyps you cannot call polyposis.
When would you say that a patient has got polyposis?
More than 100 polyps in the.
Okay. So does this patient fits into that?
Sir, actually, I want to check even upper G endoscopy to see small intestine also for the polyps. Then.
No, I think the question is very clear. I think first you should answer this question. So
Yes,
this does not fit like in the definition of a polyposis. He has multiple polyps or many polyps.
Yeah.
and then there is a family history. With this background, even without thinking of an upper GI or other things, what are the possibilities you think about?
Sir, even hereditary non-polyposis colorectal cancer also, Lynch syndrome also one possibility, sir.
You should be very strong. You should be very strong. You give as if you think Lynch will be one of the possibility. Yes or no?
Yes, sir. Yes, sir.
Why?
There is a total 3 family members and 2 related to two are first degree relatives, and other thing is the 2 generations affected, sir. And this now the patient is less than 50 years of age.
Okay.
And
Last question, what is the DD of polyps of the colon?
sir, polyps of the colon, hereditary adenomatous polyposis syndrome, sir, and hamartomatous polyposis syndrome, and other non-hereditary polyposis syndrome, sir. Coming to the hereditary polyposis syndrome, familial adenomatous polyposis or Gardner syndrome, Turcot syndrome, attenuated familial adenomatous polyposis syndrome, MU2AH associated polyposis. And then hamartomatous polyposis syndrome, Purjagar syndrome, or Cowden disease, or juvenile polyposis syndrome. And non-hereditary frontoid Canada syndrome, serrated adenomatous polyposis.
Good.
Can you have benign condition producing polyps?
Sir, hyperplastic polyps are
Okay, benign. Any other benign condition can produce polypoidal lesions.
Yeah.
I have written polypoidal lesions. Lymphoma can be polypoidal. Inflammatory bowel disease, long-standing
Yes.
IBD is one
Yes, sir.
thing. No, you
Yes, sir.
find
Ulcerative
pseudopolyps,
colitis.
no?
Yes, sir.
So true
Pseudopolyps.
polyps, pseudopolyps, and among the true polyps, benign, and those with the diaplastic potential. Okay, we'll move to the next question. These are the various polyps seen on endoscopy. You find both pedunculated as well as sessile ones. Okay.
Yes, sir.
Classification I already told. Polyposis we already mentioned. Attenuated polyposis.
When there is a polyps less than 100 in number is defined as attenuated polyposis. Usually it will affect the prime, 3' end of FAP gene on chromosome 5. What is sir?
Cap polyposis.
What is cap polyposis? It is also defined as serrated endomatous polyposis, sir, or serrated polyposis syndrome, previously defined as hyperplastic polyps.
Okay.
Management of sessile polyps, sir. So small sessile polyps, it depends on the number of the polyps. If number, size, and site of the polyp. If small sessile polyps less than 5 millimeter, just we need to take numbers, depends upon the 1 to 2 number, 2 to 10, and more than 10. If it's a size less than 20 millimeter, less than 10 millimeter, we need to just biopsy the polyps. If in between the 10 to 20 millimeters, we need to remove the polyps. If more than 20 millimeter, we need to do the piecemeal polypectomy.
No, these are all small polyps. Why do you do a piecemeal?
Sorry, small. Yes, sir.
These are all small polyps, small sessile polyps. I think the
Yes.
answer should be, what do you do with a sessile polyp of a small size? Maybe
Small.
5 or 10. What do you do?
Just biopsy.
There is no piecemeal here.
No, sir. Just biopsy and
Yeah, you have to biopsy them, and then
it depends upon the number of the polyps. We need to surveillance the patient, sir. If
Okay, is there a difference in the management of a small sessile polyp and a small pedunculated polyp?
in the management there is no difference.
Are you bothered about sessile polyps more than a pedunculated polyp?
Yes, sir. Sessile polyps, it will be more, so surveillance need to be very strict in this sessile polyps.
So what is the problem when you do a polypectomy in a sessile polyp? Complication wise.
Sir, I didn't get you.
What all
Sessile polyps
complications
are
can
any
occur after
complications?
polypectomy? Dr. Prakash, again, I think Jagdish is not understanding our question.
Yeah. So, Jagdish, when you do a polypectomy, especially in a patient who has got a sessile polyp, so there is a possibility of thermal injury to the wall. Don't you think so?
Yes, sir.
So, to avoid this, is there any methods which we use?
No,
So
no,
the thing is, we can remove this polyp even without using a cautery, without using the thermal current. So you can do a cold snare, okay? Especially with the small polyps, you can remove it with a cold snare, and that is one of the latest way of removing these small polyps, okay? The other thing is you raise the polyp from the
Base.
submucosa.
Submucosa.
How do you do that?
Sir, will infiltrate the saline.
Yeah, you can inject it. Very good. So you inject something, either a saline, or you can mix the saline with indigo
With the
carbonate
adrenaline
or methylene blue. Maybe you can add some adrenaline also, and then raise it from the base so that you can avoid the injury to the deeper tissues. Okay.
Yes, sir.
Good. I think here the last part is the difference in the management of a large pedunculated polyp versus sessile polyp. Jagdish.
Yes, sir. Large pedunculated versus sessile polyps. So large pedunculated polyp, we need to infiltrate at the base of the pedunculated polyp, we infiltrate with noradrenaline and normal saline. We will raise the base of the polyp, sir. Then we'll use the hard snare polypectomy, and we'll hard snare and
I think it is always better to use an endo loop.
yes, sir.
If you have a large polyp, even if you can raise the base, everything is okay. Either you apply a clip or you apply an endo loop. I usually prefer to use an endo loop if it is possible, if the loop can go over the polyp. Otherwise, I will use a clip, 1 or 2 clips at the base, so that I am very sure that there is no bleeding.
Okay, sir.
Injecting adrenaline with the saline, they're all good, but sometimes they can have a bleeding which can be torrential. So that is, I have burned to at least once or twice my finger, and now I do an endo loop. It will be a little more expensive, or use a good quality clips. The clip should be a very good quality one.
Yes, sir.
I don't use the Olympus clip because it is not very sturdy. I will use a good quality clip, which may be an expensive 3,000 to 5,000 rupees, but nevertheless, it is very useful in practice. Dr. Prakash, your views.
That's what you said is absolutely right. Whenever there is a practice which we also do. So when you have a thick stalk, there is a high chance that there is a vessel within that stalk, and that will bleed after polypectomy. So for that, to strangulate this, you place an endo loop and then cut above that. Okay. And also when you do a snare polypectomy of large polyp, you should be very careful. You should see that the polyp is not touching the opposite wall, and have a small wriggling movement while doing the polypectomy snare, so that you can avoid thermal injury to the opposite walls also. And always when you hold this, when you catch hold of this polyps, especially for a sessile polyp, should be careful. You should see that the opposite walls or the surrounding walls are not involved. So you have to be sure of the area which you have caught within the snare.
Next one will be the large sessile polyp. Sir. It's to raise the large sessile polyp to difficulty, sir. So in this large sessile polyp, usually we'll do either endoscopic mucosal resection or resection, sir. Then we'll apply the hemoclips to close the defect in the colon.
Jagdish, it also depends on the size of the lesion. Okay, so when it is about 2 centimeters, then you can remove it by endoscopic mucosal resection (EMR). Okay, so this can be either with a cap technique or without cap technique. Or if it is more than that, more than 2 centimeters, even up to 3 centimeters, some people that say that can be removed. But if it is more than that, then endoscopic submucosal dissection would be the one to remove it as an en bloc. So when you have a lesion which you want to remove en bloc, then endoscopic submucosal dissection is the way to do. But if the other option would be a piecemeal resection, as you said earlier, where you will not get the whole lesion removed as an en bloc, but it will be a piecemeal.
I think it will be also very useful when you do a piecemeal to get a good histology. Sometimes some of these polyps will have an underlying malignancy. I think we may think that it is not malignant, but then you may not be able to remove the polyp as a whole one. It will not be lifted. So getting a histology by doing a piecemeal is always important, and many a time we get a diagnosis of a malignancy underlying the polyp. So I think it should be with one session. I think you should not be always think that you can do it in one session. You may go at least 2 or 3 sessions.
Shanesa, you are not audible.
Am I not audible now?
Now you are audible.
Yeah, because in
I
between
think-
somebody. Yeah.
I think experts like Prakash and Mathya and all sit for 6 to 8 hours and even remove long and big sessile tumors. I think in one session you can remove it, no, Dr. Prakash?
Yeah, we usually do it in one session because, and we try to remove it en bloc. So that can be done with endoscopic submucosal dissection.
Dissection, yeah, with the dissection.
Histopathological of polyp segment colon showed tubular adenoma with high-grade dysplasia. What is follow-up of patient after polypectomy in case of adenomatous polyp? Short term and long term. Sir, this tubular adenoma with high-grade dysplasia. So I want to repeat within 6 months again repeat colonoscopy, sir, in surveillance patient.
I think like Dr. Prakash described earlier, all dysplasia need to be reconfirmed.
Yeah.
That is the most important thing. It has to be reconfirmed because you are telling that you are having something short of cancer. So I think requires reconfirmation and then you tell the patient. Okay. Dr. Prakash has to say something.
Yeah, Jagdish, one more technique is something which if there is an endoscopist in your exam room might mention is an underwater endoscopic mucosal resection, underwater EMR. Okay. That is also something and another technique which is used for sessile polyps. Okay. Large, even up to 3 centimeters. So that is also another way of of removing sessile polyps.
Dr. Prakash, is underwater or colonoscopy is also done for diagnostic purpose to increase the yield of polyps? That's what I read.
Yeah, it can be.
Even for diagnostic nowadays, people seem to be doing colonoscopy with the full colon with the water.
That's right, instilled with water.
Because polyps and all will sort of dangle into the lumen with water. Otherwise, it will stick to mucosa and we may miss it.
That is called as a hydrocolonoscopy.
Hydrocolonoscopy. Okay.
No, the people have used it. WHO has used, there is a nice manual of colonoscopy by WHO. So they call it as a hydrocolonoscopy. And then you can, it is almost a painless colonoscopy because you will be able to visualize very quickly and you will not miss any polyps.
Jagdish, regarding the polyps, when you you should also know about the Paris classification of endoscopic morphology. Okay,
Yes,
so
sir.
that is something which we should know.
Yes, sir.
Regarding polypoid, non-polypoid endoscavator, there are 3 types, and
Yes, sir.
021, 022, and 023. So
Yes,
that
sir.
is something. You should also know about lateral spreading tumor lesions. This is a classification. This something proposed by Okamoto. So lateral spreading tumors, you should know that is granular and non-granular types. So, and the malignancy risk with both the LSTG and LST non-granular. Okay. So these are certain things which you should know. And then you should also know about NICE classification. Okay. Type 1, 2, and 3. And yeah, about classification, the type 3 is something which you don't do endoscopically. So 1 is benign and 2 is the adenomatous polyp. And also you should know about the Kudo classification. So sometimes people might ask you about that. So these are certain other things you should know.
And what is the HNPCC? HNPCC is a hereditary non-polyposis colorectal cancer, also called as Lynch syndrome. Then what is Amsterdam criteria? Sir, now Amsterdam criteria 2 is going. It depends as 3 relatives and non HNPCC related cancer histologically proven, and 1 relative is first degree relative to of other 2, and second one at least 2 continuous generations, and third one is any one of the patient need to be less than 50 years of age. That is the Amsterdam criteria. Is it possible to assess the risk of colon cancer in such families without colonoscopy?
What is the difference from the 1 and 2?
Sir, 1 with only colorectal cancer, sir.
Okay.
And in 2 there will be a HNPCC related cancers.
Okay.
All.
What are the other related cancers?
Sir, it will be endometrium, uterus, and pancreas, biliary tract, and stomach, sir.
There are other Turcotte syndrome and Moyer-Tor syndromes also. Okay.
Yes, sir.
Right. Okay. Carry on.
Is it possible to assess the risk of colon cancer in such families without colonoscopy? Yes, sir. There is other non-invasive methods for that. One is fecal immunohistochemistry and stool occult blood test, or CT cholangiography.
Not cholangiography, CT.
So,
What is it called?
CTC, sir. CT colonography.
CT colonography. Yeah?
Coronography.
Yes, sir.
Okay.
Or virtual colonoscopy, otherwise called virtual colonoscopy. Okay.
Virtual colonoscopy. Yeah, that is a better term.
And what are the genetic abnormalities in inherited colon cancer syndrome? In inherited colon syndrome, like familial adenomatous polyposis, it will be chromosome 5, sir. Adenomatous polyposis collagen, and if it is in Peutz syndrome, it will be STK11, sir. And if it in MUTVH associated polyposis syndrome, the gene mutation also MUTVH. In Gardner and Turcotte attenuated family adenomatous polyposis also same APC gene, but it will be either 5', 3' in attenuated FAP, sir. And coming to the
The issue is that even though for gastroenterologists doing a colonoscopy is nothing, but patients are not very happy about undergoing colonoscopy just to know that whether there is a cancer or other thing. Okay, their first degree relative may be affected, but still they are not very happy. So if there are genetic tests which can be done when the person is very young and in genetic syndromes, and then we can predict the possibility you are a vulnerable person, you are not vulnerable person, like that you can stratify them into genetically a highly susceptible person and then subject them to colonoscopy. Then you know that this person is very likely to have, okay, those people who do not have the genetic mutation probably can be spared the discomfort of undergoing all those things. Okay, that's a new strategy which is coming. Genetically screen them, find out whether they are genetically susceptible, and then do copy according to the need. Okay.
and what are the other risk factors for colon cancer? Other risk factors will be high fat diet consumption or low fiber diet, beer and alcohol consumption.
Any diseases?
Inflammatory
there?
bowel disease.
Yes, sir. Inflammatory bowel disease, family history,
Inflammatory bowel disease. Okay.
and primary sclerosing cholangitis.
Inflammatory bowel disease. Okay. In olden days, they used to do what is known as ureterosigmoidostomy.
Yes,
When
sir.
because stent and all those things are available, and the long-term ureterosigmoidostomy used to produce a carcinoma at the site of the ureterosigmoidostomy. Okay. That was a risk which is mentioned in the book, but nowadays we don't find such patients. I think urology, they have changed the type of management. Any further questions, sir?
No, I think Dr. Prakash can assess the candidate.
Yeah,
Prakash?
There is no need to publicly assess.
that's right. So
No, but I think he has done very well. I think
yeah, you've done well. Yeah.
You want
he
to
has
tell
done
them
well.
he has done good. Well,
I
okay,
think as
good.
a word of encouragement, I think he has been one of the top 10. I think he is in the upper 10th percentile.
I want to congratulate Jagdish because you from Chennai and you from Kerala and Rohan from Chennai are the few people who are volunteering even at the fag end of your course, still coming for the volunteering to present the cases. Okay, so special congrats. That shows you are confident and you are bold to face any questions. Keep it up.
That is the reason why I thought I should assess them and say that they have done extremely well.
Okay. Thank you, Dr. Jagdish. We'll move to the next case. Rohan, are you there?
Yes, sir, I'm there.
Okay.
So this
We'll
is
be little fast in this case because
Yes, sir.
time.
We'll go quickly, sir. This is a 60-year-old gentleman, type 2 diabetes mellitus for 15 years on oral hypoglycemic agents, known case of ulcerative colitis for last 15 years, on 5 ASA, 800 milligram twice daily since long time, good compliance, used to get periodic exacerbation for which he was treated with steroids and used to get good relief, was on azathioprine for 5 years initially, stopped as per advice of doctor. Recent constipation for last 2 months, no pain abdomen, no bleeding per rectum, no significant improvement on fiber supplementation. On examination, no positive findings. For rectal examination, no abnormality detected. How will you proceed further? Yes. So this is just to summarize, the long-standing ulcerative colitis with a history of recent onset constipation. So I would like to consider various differentials for this. One is since the most obvious glaring in this case would be like for long-standing constipation, recent onset constipation in a long-standing ulcerative colitis, I would like to think about any development of a dysplasia or a colorectal malignancy in this case. The other differentials could be functional constipation, though there are no alarming features over here. But the constipation history, I would like to elicit further by asking questions like how many times he passes stools, is there any digital evacuation, does he have prolonged does he have excessive straining for defecation, and is yes sir. So to assess whether it's functional constipation, but again new onset constipation in a elderly I would like to evaluate rather than wait.
No, he was having fairly normal bowel movements when the disease is under control. Of late, he has noticed that he has to strain more, and the fecal stream is thinning out. That was the reason he took fiber after, as per the advice of the doctor. But still, after taking fiber, he is not feeling good.
So I would like to.
Do you think he requires further evaluation, or does?
Yes, sir. Any new onset constipation in an elderly patient itself is I would like to evaluate further rather than giving it benign.
So what will you do?
First, I would like to check for the blood parameters to see for any evidence of anemia, new onset. I would like to know what was his baseline hemoglobin. His hemoglobin at present is 11.4. Total counts are 5,600. Platelet 3.2 lakh. ESR of 56, which seems to be elevated for a patient who is compliant and on medication. Random blood sugar is 186. HbA1c is elevated 8.4. The liver function test is showing elevated total bilirubin 2.1. The AST, ALT are 43, 54, borderline normal, mildly elevated. Alkaline phosphatase is 256. So what was the lab range, sir?
190.
Okay, sir. So alpha seems to be elevated. The total protein and albumin seem to be normal. The CEA levels are elevated, that is 6.2, and TSH is 6.1, borderline elevated. So the next investigation of choice I would like to do is a colonoscopy in this case. So a full-length colonoscopy was done, which showed multiple pseudo polyps, 3 millimeters to 1 centimeter in size throughout the length of the colon, more on the left side. Suspicious narrowing of rectosigmoid junction area, no skip lesions, vascular pattern normally seen. Biopsy taken from multiple areas. On histopathological resection, there was ulcerative colitis with inflammatory polyp. No malignancy in the polyp specimen. Rectosigmoid area biopsy shows evidence of high-grade dysplasia. Will you proceed further? Yes, sir. So for this, there are some guidelines for dysplasia in a case of ulcerative colitis. He seems to be a patient with ulcerative colitis, which is in the second decade, that is 15 years of disease. So he is definitely at risk. He's a male patient, and we don't know whether it was a pancolitis in the beginning or not, but still he has the risk factors to develop dysplasia. He has on the biopsy high-grade dysplasia. So any patient with for the management of dysplasia in ulcerative colitis, there are CNIC guidelines which say that initially the lesions were classified as either a dysplasia associated lesion or mass or DALMS, or currently the classification is endoscopically visible lesions and endoscopically invisible lesions. So here there's a obvious visible stricture over there, and he's symptomatic for constipation. So and there is high-grade dysplasia. So any high-grade dysplasia, proven malignancy or carcinoma, or low-grade dysplasia, which is multifocal, are indications for colectomy. So I would suggest the patient total proctocolectomy in this case. I would offer him options such as a total proctocolectomy or an a subtotal colectomy with ileorectal anastomosis, and then go for a aggressive surveillance in the rectal stump because of the possibility of recurrence of disease. and the other would be an ileal pouch anal
Can you repeat that,
anastomosis.
Rohan? Can you repeat that last sentence?
Yes, sir. So, in case
You said one option is to have a total proctocolectomy and
yes, sir.
ileocystomy.
Yes,
Second,
sir.
you said subtotal colectomy and
Yes, sir. Till the distal
rectal
rectum
anastomosis.
that is beyond the stricture area, distal to the stricture, we can
I think
anastomose.
as we have no idea about the extent of the stricture, we have not assessed it correctly. And
Okay.
rectosigmoid means if you are suspecting a growth, I think you have to be careful.
Yes, sir.
Because unlike in the case of colon cancer, in a de novo normal colon and ulcerative colitis, you may have multiple areas with involvement, and therefore must be careful.
Yes,
Okay.
sir.
Actually, we have to confirm the high grade
With,
dysplasia and then start the strategy. Okay.
yes, sir. In this case, I assume that since it was in the rectosigmoid, I thought it was a upper rectum and sigmoid. So in that case, I thought more like a carcinoma of the sigmoid and upper rectum. But in either case, the best option would be a total proctocolectomy with either a permanent ileostomy, which can be a Brooks or a Cox continent ileostomy, or a ileal pouch anal anastomosis.
That you already mentioned.
Yes, sir. What is
And
the
another
risk?
thing regarding the biopsy, do you have any comment on the biopsy in a patient undergoing colonoscopy in such a situation? Do you think the biopsy was optimal?
Yes, so maybe I would like to cross verify and confirm it with, because just like Barrett's, I take a second opinion on the biopsy.
No, my question was that this particular patient had biopsy from the rectosigmoid, and then he had pure random biopsy from the polyps. Do you think that was the sufficient method of, it was the correct method of doing?
No, sir. The
In other
correct
words, what would be the right method of doing a surveillance colonoscopy?
Yes, sir. Initially, the CNEC guidelines, what they had suggested is biopsy every 10 centimeters and quadrant, 4 quadrant biopsies up to 32 biopsies, but current and apart from targeted lesions. So targeted lesions in this case would be a stricture or the pseudopolyps or any visible dysplasia as per the Paris classification. So in those would be the targeted lesions, and it can be either done with these can be identified either with the standard high definition white light endoscopy or with the use of digital or dichromo endoscopy. But the recent studies have shown that white light high definition white light endoscopy is equivalent to a chromo endoscopy or a digital chromo endoscopy. So it would be either 10 centimeter biopsies in case no visible lesion is identified, and targeted biopsies in case a visible lesion is seen. That would be the method of surveillance.
Will there be a difference in the appearance of the colon cancer and ulcerative colitis? What is the problem? If the growth can be found just like in any other colon cancer, you will not miss it, no? So is there a problem? Is there a real issue?
Yes, sir.
So you had mentioned about endoscopically visible, endoscopically non-visible, polypoid, non-polypoid.
Yes, sir. So as per the Paris classification, we can grade them. So that is whether it is polypoidal, sessile, polypoid pedunculated, or it is flat, where it is flat,
Okay.
elevated,
Rohan,
flat.
it is not the classification which we are asking. We are asking if
I
when
think,
you do.
I think
Yeah.
what is very important is that these lesions are more like flat lesions.
Flat and
They are not
infiltrated. Yeah.
They are not protuberant lesions like any other CA colon. I think
Yes.
a great degree of suspicion should be there in a given case. And then, as Dr. Varghese mentioned, it is the suspicion and then taking multiple biopsies from multiple areas. Sometimes what you think normal may be an area of malignancy. That is what I find in some of the ulcerative colitis. Paris classification is not what is required here. What is required here is to identify that lesion, which is either dysplastic or malignant.
Yes.
Dr. Prakash, anything to add?
Yeah, that's so. There can be, I mean, multifocal involvement. There can so, and any of this lesion can be endoscopically invisible. So some people now say that I mean, in expert hands with the use of chromoendoscopy, many of these endoscopically invisible lesions, if you look at it very well, it would be seen well, and also with the use of artificial intelligence. So if you can incorporate artificial intelligence, already Olympus has brought, I mean, has tied up with another company, and they have brought it up. So use of artificial intelligence into this endoscopy might increase the yield of these dysplastic lesions.
And latest techniques of molecular technology also will identify abnormalities at the nuclear level, and even chromosomal studies on the tissue which is taken from the colon also will tell us the risk. So newer techniques are there, completely different from older techniques. Okay, maybe things will change in a dramatic way in the coming years.
That's right.
Okay, thank you, Dr. Rohan. Thank you very much. It's 9:25. Should we take the next case? Jagdish, do you want to take up the next case?
Sorry, your wish, sir.
What do you feel?
What do you feel? Only up to you.
I'm ready, sir.
You are ready. Okay, we will do it fast.
Good.
We appreciate that.
That's right.
A 62-year-old female presented with long-standing dyspepsia, no alarm symptoms clinically, no significant abdominal pain, type 2 diabetic mellitus, and hypertension on treatment for 10 years. Ultrasound abdomen showed cystic lesion, 8 centimeter size in head and body of the area of pancreas. How will you proceed further?
What next?
Sir, it's a cystic lesion, 8 centimeters in size, and 62-year-old female, sir. And there is no
4 centimeter, no?
Pardon?
What is the size? 4 centimeter or 8?
No, 8.
8 centimeter. Okay. Right.
Sir,
So how do we proceed?
Next investigation, I would like to do CT abdomen plain and contrast, sir. An examination.
Okay, mass. Okay. What do you think about the CT?
Sir, there is a central scar is there, and heterogeneous.
Okay, there's a multicystic lesion with a central scar-like appearance. So, what is your diagnosis?
Serous cystadnoma, sir.
Okay. So, what will you do now? Leave it like that or operate?
Sir, cyst not having any features.
Are you there?
Like, yes, sir, I am here, sir.
Yeah. So, what do you think?
Sir, there is this very unlikely it will become a malignant, sir. It's not a pre-malignant condition. If there is no other features of any gastric outlet obstruction or obstructive jaundice or any symptoms like persistent abdominal pain, so I would like monitor the patient, sir. Follow up.
Okay.
Okay. Okay. Suppose you are not seeing this scar here.
Yes, sir.
Now you got a scar, which was very easy. So the chances of it being a serous cystadnoma is very high. If that scar was not there, it would have been a cystic lesion in this age group. What will you consider?
Sir, then I want to go ahead and do the endoscopic ultrasound and aspiration of fluid for cytology and cystic fluid for CA99, CEA, not CA99, CEA.
So is the cyst analysis very sure of differentiating it?
Would you like to do another imaging, or you would straight away go for endoscopic ultrasound? Is there any advantage of CT or MRI?
Sir, I would like to go ahead and do endoscopic ultrasound FNA, sir. It will be more sensitive than other imaging.
The question was that when a patient comes like this, you want to supplement it with any other imaging like MR, because CT has already been done.
Yes,
The
sir.
only option is MR. So do you want to do that or straight away go for EUS? Do you have any advantage of doing EUS over MR? You said no, cyst aspiration.
Yeah, cyst
MR has its
aspiration.
own advantages, especially pancreatic tumors. MR seems to be now people are preferring MR over CT. But EOS has advantage because you can also do the cyst aspiration and analysis of the cyst fluid.
Yes, sir.
Okay, so first thing, what you do, how do you assess the viscosity?
Viscosity first is palpatory method, sir. String sign I want to check, sir.
String sign. What is string sign?
So place the pancreatic aspirated fluid between two fingers and stretch the finger. So we'll.
Have you heard of any other string test in gastroenterology? As Rohan said, these are all historic. Your examiners may be very old sometimes. Then they may ask you. In olden days, for even GI bleed, people used to do string test, passing a long thread into the GI tract. They are asked to swallow some capsule-like thing with a string. And looking at the position where it is stained, they will try to roughly assess where is the lesion. And then olden days, they used to do laparotomy on the basis of that. And there was a string test again used to look for parasitic infestation. They used to pass the same thing into intestine and pull it back and then squeeze the fluid into a glass slide and examine under microscope. So in olden days, this sort of string tests were there, purely historic. Okay, those who are interested in history may listen, otherwise forget it. Dr. Prakash, do you want to add anything now?
So the thing is that why certain people prefer MR over CT is that though I mean CT, none of them is purely diagnostic, but if you can get some features which are very suggestive, then it is good. But MR is very sensitive for identifying multiple cystic lesions, multifocal side branch IPMNs, and also to look at the pancreatic duct as such and its communication. And when you do a cyst puncture, there are certain things which you should know or which you should keep in mind. One is that we should give an IV antibiotic. That is a recommendation, though there are certain newer studies which say that there may not be any need. But for all practical purpose, if you are asked, you should say that for cyst puncture, you should give IV antibiotic prior to the puncture. And if there is a suspected mucinous, then a 19 gauge needle is something which you should use, because then only you can aspirate the fluid. Otherwise, if it is a 22 gauge, the fluid may not come in. And if it is whenever you puncture the cyst, always put on the Doppler, see whether there is any vessel, and also on the along the track, if there is any vessel, you should avoid that so that you can prevent any bleeding. Then if it is there can be oligocystic serocystic lesions. In that case, if you can aspirate the whole cyst, then that can also prevent an infection. Otherwise, if you leave the fluid behind, then there is a risk of infection. So the complications of this puncture are bleeding and infection. So these things you should know.
How do you differentiate IPMN from this sort of lesion? Can this be an IPMN?
Sir, IPMN, there will be always pancreatic duct dilatation, sir. Along with in side view endoscopy, there will be bismuth appearance with
okay, if it is of the main duct, Even fish mouth appearance and the big plug of mucus protruding through them. It could
Okay.
also be a side branch IPMN wherein it may appear like a cystic lesion, and you may not get the classic main PD dilated and the fish mouth appearance. Okay, and you want, just to have an idea about how you differentiate various tumors, pseudocyst, cystadenoma, all other things, because Schlesinger gives this table. I think just know about it, and if you are asked about the parameters which are checked: viscosity, amylase, CA, CA72, done in some lab, and of course the cytology. Okay, these are the things which we should look at it. Okay.
The other thing is, regarding EUS, you should also know about the contrast enhanced EUS and the contrast which are used for that. That is sonozoid and sonoview. If someone asks, you should know about it. Okay.
Yes, sir.
Okay, and another thing which one should know is that just read up these sort of things, exact DNA changes which happen in various tumors and cysts, etc. This is all given in your textbook. Okay, I just wanted to show you because in OSCE sometimes they may ask like that. They may show exactly that CT finding, ask you to make a diagnosis, which you may have only 1 mark, and then ask you to do the tell us the chromosomal changes which may occur in the cells, which may have 4 marks. Okay. And another trend nowadays is that they ask about the trial. For example, if it is a new drug, etc., they'll ask about ask for which trial this drug was found to be useful. Okay. So in the net, we have various sites where you give details about the trials in gastroenterology. Please learn up most of the trials. For example, newer drug like tofacitinib has a few trials in. Okay, and similar things are there. Okay. I think it's 9:35. Ranay sir also already left, no? Sir, shall we stop now?
Yeah. I think
9:30.
we have discussed 4 cases sufficiently well. And I think it is time that we thank our students for their excellent presentation. Dr. Prakash Sakaria, Dr. Varghese Thomas, and all the others who have been very actively participating. Dr. Varghese Thomas, we thank them and then we stop the proceedings today.
And sir, wish them all the very best
Yeah.
for the examination. They all want your blessings.
I think we will wish them all the best in the exams.
Because they have been like our children, no? They have been with us for 6 months, regularly attending the program, and in spite of having a lot of personal problem, we pressurize them to attend the class, no? So we have to wish them very best for their examination.
I think
No, they will all do well.
would be having a lot of palpitations and stress.
Yeah, I am having more stress nowadays.
I think he has done a lot of hard work. I think for all their achievements, you have to take credit because you for the last 1 year you have been preparing a lot. All these slides which you have prepared, I know how much time you must have spent preparing these slides, going through these cases. So it's a remarkable feat.
I think it is worthy of a big applause.
Thank you all very much. Thank you all very much. It's time to wind up. So once again, I want to thank all of you, plus thank Sun's Sickness Division for providing this platform for us. Thank you very much. Good night.
Thank you, Varghese.
Thank you very much.
Prakash and everyone. Thank you.
Next week, we have Professor Venkatakrishnan again doing only OSCE on liver disease. And after that, you may have an X-ray session. There won't be any interaction. We can plainly watch, and then we'll close the session for season 1. And we will also take a break for first half of September until your exams are over. And then we will come back with the season 2 later, next month.
Okay.
Good night, all of you.
Good night. Thank you, sir.
Thank you. Have a nice time and good night.
Good night.